certainly this really challenging time has motivated our presentation today. And so wanting to take a moment to acknowledge that right now in Hagley Park, there's a national memorial taking place. And just for us all, perhaps, just to take a moment to connect silently in our hearts and minds with that occasion. Thank you. And as Michele was saying, I am a senior specialist therapist and I hold a master's degree in counselling psychology, and a part of my working life is with Tamaki Healthcare or Nirvana Health Group in Auckland, New Zealand, New Zealand's largest primary healthcare provider, and there I run a mindfulness program that is being enriched with Te Ao Māori through a Counties Manukau District Health Board funding initiative. And I see clients in one of our doctors' clinics there, and I also offer our mindfulness course for staff. I also run a private company called Mindful Life Consulting, and you'll see that on your screen. You're most welcome to contact me if I can be of service to you. I do run mindfulness workshops and groups, offer therapy and supervision in person in Auckland and on the internet as well. So that's a little about me, and you might have been aware that I served for a number of years as a hospice interfaith chaplain and as a trauma chaplain and grief counsellor as well. So we can go to the next slide now, Michele. And all of you will recognise, undoubtedly, this beautiful model, Te Whare Tapa Whā, which is meaningful for Māori, our Indigenous people. And I wanted to begin this presentation by just touching upon the great relevance of acknowledging cultural differences as we begin this session today. Māori teach us, and unfortunately teach us constantly, that we sometimes miss what is most important to them as a collective society, and also as people who are deeply spiritual. And I think we've seen, in the last days, in fact, I was listening to Radio New Zealand yesterday, and one of the Muslim leaders was talking about offering care to their community, and particularly discussing the relevance of integrating the survivors of this trauma back into community and helping them out, within the context of community and their faith. And so often for those who are other than perhaps New Zealand European, these things are primary. And so we know that cultural beliefs really do influence our personal meanings of trauma and our attempt to come to terms with trauma in helpful ways. And that there are real cultural variations, in fact, in the way that we look at diagnoses such as post-traumatic stress disorder. In our individualistic cultures, we tend to more frequently look at a person's vulnerability or their self-care, whereas collectivist cultures focus more on how is that person functioning in society, how are we seeing them in our community. And so most important that we note that. And was about a decade ago that there was a really significant tsunami in the Pacific Ocean, and a number of Western psychologists, physicians and volunteers went rushing over, really wanting to help those people, but not really understanding what that meant in that cultural context. And unfortunately, coming in with our own initiatives, we caused, in some cases, more problems than care. Expecting people to grieve loudly, expecting them to speak about their experience prematurely, and engaging members of the community without going through the necessary protocols first. So this is something I think it's so important that we're mindful of as we engage people who have experienced trauma. And in my work as a bereavement therapist, one of my favorite teachers was a man by the name of Dr. Alan Wolfelt, who hails from Colorado. And he talks about taking a teach me philosophy, that we approach people seeking to understand and to learn, what is happening for you? How do you see what is happening? And how can I walk beside you in a way that will help enhance your recovery or discovery of the resources that you need, that you require, that you desire? And we can go to the next slide now. Thanks, Michele.
Absolutely.
And so this is a quote from Dr. Rachel Naomi Remen, who is a physician in the United States, who's quite renowned, and who actually suffered a very chronic health condition during her training. And she's written several books upon her experience as a physician and as a woman living with chronic illness going through her training. The expectation that we can be immersed in suffering and loss daily and not be touched by it is as unrealistic as expecting to be able to walk through water without getting wet. That sort of denial is no small matter. The way we protect ourselves from loss may be the way in which we distance ourselves from life and from hope and help. We burn out not because we don't care, but because we don't grieve. We burn out because we've allowed our hearts to become so filled with loss that we have no room left to care. And most certainly our time today is about addressing that need to find room to care and to care for ourselves and each other. We can go to the next slide now. Thank you. And so this is a word that is frequently on our lips at times such as these, post-traumatic stress disorder. And I wanted to speak just briefly to this condition and to some of the other Western diagnoses that we might be using as we discuss the people that we're working with, and also as we talk about ourselves and our reactions to being with grief and trauma. There is a new diagnosis now in the Diagnostic and Statistical Manual of Mental Health Disorders, and there is a link to that on this slide for you. And this diagnosis does include those of us who may be exposed not only to a direct event of trauma, but also to the details or the stories about that trauma that occurred. And I'd just like to touch quickly upon some of the symptoms of PTSD. You may be familiar with these. So direct exposure to the event or details being the first one. Intrusive symptoms, being the next. And this is this experience of thoughts, of feelings, of images, of smells, of sensations arriving like intruders in our mind-body experience. And so they often feel like quite an affront, and our tendency is want to stop them or to avoid them. They are, however, nature's way, we might say, of trying to help us to integrate these very extraordinary and challenging events. So though we may be afraid of such symptoms, they are actually healthy and normal symptoms to experience. The next criteria is avoidance. We put that brake on. We don't want to remember. We don't want to feel. And this is where we can so often get into trouble, is avoiding thoughts, feelings, or sensations, avoiding people, places, and conversations that remind us of that event. Another criteria, negative changes in our thought, our mood processes, the inability to remember, self-blame, the blame of others, negative emotional states, loss of interest in activities, feeling detached, and not being able to feel our usual positive emotions, which is, of course, quite natural, at such a time and a part of our grief process, whether we suffer from traumatic stress reactions or not. There are some others, aggressive behaviors, irritability, impulsivity, self-destructive behaviors such as overuse of drugs and alcohol, feeling constantly on guard. You know, we do become quite hypervigilant at such times naturally. The people I work with in my therapy practice, we sometimes say, you know, they're a bit like hot-wired cars, and that's often a helpful metaphor for them. You know, they can go from 0 to 100 and not feeling safe or feeling upset or angry very, very quickly if they feel threatened, because trauma really does affect our emotional brain, so to speak. The brain is actually a very integrated and interconnected organ, but we can pass out that it's the emotional brain that's most affected when we experience trauma. And we literally don't process information in the same way. We cannot absorb the enormity of that event while it is happening. And so it registers then as feelings, as sensations, as images, and so on, as sensory experiences rather than a narrative. And part of the healing, of course, is finding our way in the right way for us to constructing a narrative, constructing meaning that allows us to live with. We may never forget, but we can learn to live with such experiences. And so the last criteria for this diagnosis is that we would have had these symptoms for about a month. And we can go to the next slide now, Michele. Thank you. And so we hear of this often as well in the work that we do, vicarious traumatization. And you can probably see the symptoms there, and how vicarious trauma affects us as we offer our care and support to others. And because we're talking about volunteers today, I wanted to particularly touch upon some of the concerns that affect volunteers. And this is from a paper called The Meta-Analysis of Risk Factors, for Post-Traumatic Stress Disorder in Trauma-Exposed Adults, and includes our volunteers. And you have quite a hefty list of references that will be sent out to you with the PDF for this presentation, so you'll be able to read more about these things there. But we are aware that volunteers' vulnerability, and not only volunteers, you know, I should say, and sometimes it's hard to draw the line between, you know, who is the professional, who is the volunteer. You know, volunteers come to us with so much expertise as well. But they are sometimes susceptible to lack of pre-screening. So we might not always understand the lived experience of the volunteers that are serving with us. And this can cause them to be a little more vulnerable to risk, because it's harder to care for them and to offer them appropriate, you know, work or relationships, you know, when we don't always know what history they are bringing. There's often more conflict and demands, you know, due to a volunteer role happening on top of our own perhaps full-time role or our role with our family. Volunteers often have less training regarding critical incidents and mental and emotional and physical concerns, and so they may not be as well prepared as those of us who have an idea what to expect in our experience. And they can sometimes then experience greater structural barriers to receiving the care that they need. We've learned that if there are a lot of critical events, that can have a particularly strong influence on volunteers. And so the number of times, the frequency, the duration that they're called out to offer support in crisis situations or very deeply heartfelt situations can have an impact. We also know that if they have some experience of that, or that they expect that these things may happen, that that's actually a protective factor. You know, as hard as a certain circumstance might be, you know, let's say a child who is living with dying, you know, if a volunteer has worked with that population and has an understanding and a passion for that, that can actually serve as a protection, you know, rather than a challenge for them. We also know that while volunteers who live with mental and physical health conditions may experience more stresses, that those lived experiences also make them rich, you know, give them more appreciation. And so it's so important for us not to shame or pathologize volunteers and employees who have lived experience of mental health or physical health conditions who are going to help. In fact, there has been some research that says that they sometimes do better, you know, because they have a deeper passion and a motivation, and many of them have done a lot of healing work or have access, you know, frequently to support. And I was working with a number of peers recently who were responding to people in trauma, and yes, you know, they were experiencing slightly more symptoms than usual, but they also understood those and had great empathy for those that they were working with. Another factor here, excuse me from looking up and down at my page, is that factors operating during or after a trauma, such as its severity, lack of social support, additional life stresses, have stronger effects than pre-trauma effects. And so knowing what's going on with folks, you know, as they're helping is actually quite critical. And we can go to the next slide now, Michele. And so this one is called, you know, compassion fatigue. And I think we might use that a bit. I know in the context of my own work, and my colleagues will sometimes say to each other, yeah, I'm feeling a little bit of compassion fatigue right now. And so this is quite similar to vicarious trauma. But currently it is including this domain of burnout. And we can move right along there, Michele, to the next slide. And so we call burnout a defensive response to prolonged occupational exposure to demanding interpersonal situations that produce psychological strain and provide inadequate support. And so structural support is known to be really critical in helping to avoid burnout. And so this refers directly to our systems and how our systems are supporting those that volunteer. And we can go on. Thank you. And so this little kitty, I think, kind of tells a story about stress that may be familiar to a lot of us. I'm so stressed out over being stressed out that I can't even remember why I'm stressing out. And it's stressing me out. And so from a neuropsychological perspective, we might describe this kitty as being in a state of chronic hyperarousal. And so we know that our nervous system is really sensitive to our thoughts, to our feelings, and to our physical sensations. And when our nervous system detects that we are worried or we are stressed or we are fretting, you know, due to our experience, what happens is it starts to send out the troops of adrenaline and cortisol and norepinephrine. And this causes that fight or flight reaction that we experience when we're unduly stressed, when we're experiencing trauma, and unfortunately sometimes when we're wrapped up in our duvets at 2 a.m. in the morning because we're worrying about something, you know, at that time. And I would say that there would be many of us who are listening today who've experienced that. And that's where the mindfulness teachings really come in. And so we can go to our mindfulness slide now. Thanks, Michele. And so a couple of clinicians, Sainsbury, Graves, and Scott, have been studying how to manage traumatic stress responses among helpers. And what they have really noted is that our ability to monitor our mind and body and our state of arousal is really critical, both when we are engaging in helping and afterwards as we are noting its effect on us. Yes, that's quite right. Freezes is there. Thank you, Peter. Freezes included there, fight, flight, or freeze. And actually there's another one called tend and befriend that was researched, not that long ago, that refers to our tendency to reach out, at such times for support. And so being aware of our arousal states and being able to modulate our arousal state is really significant. And I'd like to introduce you now to a practice called the centering breath, which can be enormously helpful. And so we're going to move from a highly cognitive space of sharing some information into a mindfulness state. And if you'd like to join me, what I'd like to invite you to do is just to put your hands down on your lower abdomen, just below your belly button, and just invite your belly to be soft. If you have the luxury of undoing a zipper or a button, feel free to do so. Otherwise, just relaxing that tummy as much as you can. And so as we exhale, we're going to actually draw our abdominal muscles in a little and push the air out as if we were deflating a balloon. And then as we breathe in, we're going to allow the belly to expand out as if we were blowing up a balloon. So take a few moments just to focus on your belly. And just being with that wave of breath for a few rounds. Breathing in, the belly expands out, and you're welcome to close your eyes if you'd like to. Michele's role modeling for us. And as you exhale, just allowing the belly to fall back in again. Thank you. And if you found that a little challenging, don't be surprised. Often we're not really using our diaphragm, the large muscle that sits between our rib cage and our abdomen, when we're breathing, particularly if we are stressed. And we know that people who have experienced trauma often have a lot of tightness and sometimes difficulty in this area. And so then we go up to our rib cage area, and if it's comfortable for you to place your hands just gently against your rib cage, as we breathe out from here, we'll feel the ribs just falling in. And as we breathe in, they'll expand out against our hands. So just breathing in and out of the rib cage. And as much as you're able, just bringing your attention to the physical sensations of your breathing. The ribs expanding and contracting with each breath. Thank you. And now we're going to place our hands on the upper chest, which is where, if we're living with anxiety, we often feel a lot of tension and also a rapid, shallow, kind of breath as anxiety arises in the body. And it's true, that if we experience anxiety, we may not be good friends with our breath. But breathing well is our birthright. And my experience in working with people with trauma, anxiety, and in our mindfulness course is that if we take the time to teach these practices well and encourage patience with them, they can actually be life-changing. And so placing the hands on the upper chest and just taking a few breaths here. And as you exhale, you might just like to imagine that any kind of stress is just falling away from the body, that the neck and the shoulders are relaxing with each out breath. Just breathing in and out of the upper chest now. Okay, now I'd like to invite you to take your right hand and place it back down on your lower abdomen and just leave your left hand over your heart. And you might think of your hands as like hands of compassion. Feel their warmth as if you're giving yourself a hug. And if I wake in the night and I can't sleep, I'll often lie on my back in this way and just take some deep breaths, which is what we're going to do now. We're going to join these three areas of the lungs together as if our body were like a vessel or a vase. And we pour the breath in and we fill from the lower to the mid to the top of the chest. And then we pour the breath out again from the belly. So we're following this wave of breath with our attention as we rest here with one hand on the heart and the other on the lower abdomen. And let's start with an out breath because we can't fill if we're not empty. So breathing out. And then breathing in from the belly, the top of the chest, and then breathing out from the belly again. And if you're comfortable closing your eyes, I would invite you to do so. And to bring as much of your attention as you're able just to the physical sensations of your breathing. Inviting the mind to ride that wave of breath. And you might like to breathe in a quality such as peace or calm, and as you breathe out, to just let go of whatever is there to be released right now. And gently releasing the practice. So what this does, the mindful or centering breath, is it elicits a relaxation response in the body and the mind. And so if you were able to breathe slowly and deeply, you would be experiencing lowered blood pressure, a lowered heart rate, and possibly a clearer, calmer mind. In the field of psychology, this is one of our first practices that we'll offer for people who are living with post-traumatic stress, anxiety, or difficulty regulating their emotions. Because we know that if in those really distressing moments they're able to make contact with the breath in this way, they'll have a powerful opportunity to regulate their nervous system and thus be able to think more clearly and to respond rather than to react to whatever situation they're experiencing. So we're going to whiz through the next couple of slides so that we have a little bit of time for questions. And this is Rick Hansen. I would really encourage you to visit his website. He does an enormous amount of good in this area of neuroscience, positive neuroplasticity, and working with healing from a very psychoneurological perspective that is also deeply respectful of cultures. And we can move on. Next slide, please, Michele. And so we're just going to move right through these next slides. They come from James Carmody, who was the research professor at the Mindfulness-Based Stress Reduction Center for Mindfulness in the United States. And you can just go right through those. Thank you, Michele. And I'll let you take some time to look at that, or to look at that source of his paper if you're interested in understanding more of the psychology of mindfulness practice and the utilization of the breath. And we can go to the next one, please. But this last slide really shows us that when we bring our attention to the sensations of our breathing, we're able to cut through distressing cycles of thought, feeling, or a fixation on bodily sensations. And so attentional processes in mindfulness practice help us to cut through that tendency to fall into states of anxiety and or low mood, and we can move on. And to the next, please. And what this does is it enables us to experience what is called a state of meta-awareness. And so rather than being sort of pushed around by our thoughts and our feelings, we're able to witness them as events that are passing through the mind, passing through the body. And when the worry train comes along, we don't have to get in and go for a ride. You know, when we feel anxiety rising, we can notice that. That is part of our experience, but it's not all of our experience. And so we're creating a space between the stimulus and our response to it. Viktor Frankl, you may be aware of him. He was a wonderful Austrian psychiatrist who survived Auschwitz concentration camp and was subject to extreme trauma. He says, in between the stimulus and the response, there is a space. And in that space lies my freedom to respond, regardless of circumstances, is the last of the human freedoms. And it touches my heart, but what it brings to mind for me is the fact that during the tragedy in the mosque in Christchurch, that's exactly what a lot of people were doing. They were helping others. They were praying. You know, they were contacting loved ones. And they found that space to do what was most meaningful to them, you know, during those last moments. And Frankl witnessed that too, in the situation that he was in, that it's possible for us to rise up, you know, in the face of tragedy with resilience and dignity and love and compassion for humanity. And so we'll move on. And this is a slide, you know, that just invites us, you know, to dwell in our wise mind. And so when we are in a state of mindfulness, when we're more able to witness and allow and tend to whatever's happening in the mind and body with kindness, we're able to come into that place within us that is the wiser place, not pushed around by our emotions quite so much, and not taking refuge only in that clinical, cool and rational mind, which is often a way of actually avoiding what we're feeling. And we can move on. Michele? And in my own practice, and I think it may be helpful in yours as well, to focus on positive psychology. You know, when we talk about these difficult things, positive psychology is the science of human flourishing. It invites us to find meaning and purpose in our lives beyond material gains, beyond you know, instant gratification, so to speak, that piece of chocolate cake, although with a friend it can be really wonderful to have that, to engage in activities that really bring about gratification and a sense of flow, to cultivate wholesome, positive emotions, to nourish connectedness in relationships, and to nurture and notice accomplishments for their own sake. And some of us will be aware of the Mental Health Foundation's teachings on mastery, belonging, and connectedness is really key to well-being. And we can move on. Thank you, Michele. And so I've got some strategies here for you. And I'd just like to go through these quickly with you. And I've passed these out from my own experience as well as some of the resource. It's really important for us to provide psychoeducation to volunteers who are going to be working in difficult situations. Knowledge is power, and if we understand what we can expect and what we're experiencing, that can make such a difference. Often when I'm talking about trauma in my trauma-informed mindfulness program, participants approach me later and say, oh, thank goodness, no one has ever explained what's been going on in my mind and body for all these years. Now I know. Make necessary the capacity for volunteers to identify their strategies for self-care. Normalize and validate compassion fatigue and vicarious trauma and societal and personal challenges to expressing grief and practicing self-compassion. We're often not that good at that. We've been taught frequently in our societies not to show our feelings, not to express them with others, and also to care for others, before caring for ourselves. It's important that leaders model self-care, that we show how our own health and well-being is a critical factor in our ability to assist others. This is very important. Encourage people to breathe well, to learn to reduce arousal, to elicit the relaxation response, and to increase interoception, mind-body awareness. Because according to our researchers, when we're with the other and the other is in crisis, we need to be able to monitor what is happening in our own mind and body at the same time as we are with them, so that we can modulate that and not get lost in their experience. Facilitate participation in an evidence-based mindfulness course. I think, sharing this program with our doctors and nurses in Auckland, I just hear so many glowing reports at how mindfulness practice has helped to reduce the great stress that they're frequently under in primary health care. Make sure you provide a peer supervision group or other regular opportunities dedicated to sharing the impact of the work upon our well-being, so that we can support and inspire each other. Encourage people to take time out, to connect with nature, to connect during the day to those things that are meaningful and supportive. So we really need to be active grievers, not to wait until it's too much or it's too hard, but we also need to be aware that people need a variety of supports. Critical incident stress management and critical incident stress debriefing can be really useful, but they're not always appropriate. So it needs to be situational, and we need to understand the population that we're working with and what will be of most benefit. So creating that culture of actively aware grieving, sensitively aware of cultural differences, and including things like art making, movement, poetry, writing, so that we're not just always in a cognitive space, but also in a mindfulness and creative space at times. And we often have people around us who are full of resource. I've spent some time at Hospice West Auckland, and I believe some people are listening here today, and the artist Tiffany Singh provided them with a living sculpture, that they have in their community space. It's a whole wall dedicated to grief support, where people can come and interact and place objects and sacred things upon that wall as a part of their healing process, both volunteers, families, and staff. Encourage relationship needs to be met outside of volunteering or work. It's really critical that we don't take everything from the people we're working with, but we're resourced elsewhere. Support the identification of personal values and philosophies, and know what your values and your philosophy is. And when the going gets tough, play to those values. I'm just going to take a couple more minutes to touch upon this slide on empathy, Michele, because this is really critical. Post-traumatic growth, I'll leave you to enjoy that slide in your own time, but it's the positive psychological take on the growth that can come out of trauma. It's a true thing. Not to be used as a trite remark or a suggestion at the wrong place or time, but the people we're working with share with us that they experience it. This next slide comes from some very new fMRI research on the minds of meditators undertaking loving kindness practice. And it talks about 3 kinds of empathy. I think this is one of the most powerful pieces of information I've encountered that I want to share recently. So cognitive empathy is when we know intellectually that someone is suffering. And sometimes we take refuge in that space when we're overwhelmed, and you might have felt that tendency to close the heart and withdraw a bit and just to stay cognitive in such a situation. Emotional empathy is when we do get lost in the feelings of the other. We become upset. It's natural that we do. It's natural that we grieve. It's natural that we struggle, in our service provision, and in encountering particularly stressful situations. It's completely understandable that we hear at times, but it's not helpful as our modus operandum in helping others. Empathic concern is extremely helpful. So when we are experiencing empathic concern, we are actually holding the other with love and kindness. And it calls upon the same parts of the brain as our maternal feelings do. So rather than getting lost in the upset of the situation, we're with it in a loving way, in a concerned way. And so this is a very powerful protective factor. We can look at the next. This is Kristin Neff. Some of you may be aware of her work on self-compassion. Self-compassion can be really challenging at times. We are taught, as I mentioned earlier, that we should give to others, that we're not worthy of receiving care. We may have a very strong inner critic operating that prevents us from doing so. And it can take a little bit of practice. But Kristin Neff talks about self-compassion as being comprised of self-kindness rather than being harshly critical toward oneself, as seeing our own suffering in the context of our common humanity. So I'm not alone, and nor do I need to isolate myself or feel ashamed of my suffering, but rather I always know that there is someone that feels like that. There's someone else. And I don't know if you've had, that opportunity. I think most of us have had the opportunity to be vulnerable with trusted others. And it can be a real deepening of our own self-awareness and our relationships to allow ourselves to be so. And then mindfulness helps us to hold our sorrows in a more kind of balanced awareness and acts as a protective factor, toward the suffering we might experience in our work, in our relationships, in our failures, in our struggle to sometimes meet our own expectations and those of others. And I'd just like to close with a very brief practice. I see it looks like there's only one question here, so we'll have time for that. And we could take just about 2 minutes to close this part of our seminar with a breathing practice that is a self-compassion practice. So I'd like to invite you again to just place the hand on the heart and on the lower abdomen. And once again, to just invite your awareness to drop down from that cognitive space to just being with the movement of the breath in the body. And as you breathe in, I'd like to invite you to breathe in with awareness of what you're feeling right now. Just noticing thoughts, noticing feelings, noticing physical sensations, perhaps the need to rush off into the day. And as you breathe in, just touching that experience with kindness, allowing some space for it to be as it is, because it's here now and it's part of your experience. And so breathing in and opening the heart and touching in to what is here, just as much as you are able. And now as you breathe out slowly and deeply, please offer yourself whatever might be helpful or healing. Sending self-compassion toward oneself with the out-breath. There may not be words to describe the sense of simply witnessing and companioning one's own experience. Or it may be a very active practice of sending courage or strength or comfort. And in the last moments of the practice, returning to just simply being with the rise and fall of the breath. And releasing the practice. And you'll see here that Michele has placed up a slide, and so I've provided you with a couple of links. One is to the centering breath practice, and the second is to the open heart, or the open heart practice is there for you. They're both longer, than we had time for today. So I would encourage you to try those. Most certainly myself, my colleagues, and those that I work with have found these to be helpful. And I'm just going to open this question here. Oh, it's done it, and I had to go. From someone who is with us today. Does anyone else have anything that they'd like to query before we go? I can see there's a lot happening on the chat.
I received a couple of questions via email, Lila, but I'm happy to read them out. But I suspect you may feel like they've been answered through what you've covered today. But so just go at the top one. Oh no, here it is. Sorry, I'm looking at the wrong piece of paper. How do you effectively address vicarious trauma experienced by volunteers who work directly with affected communities?
Mm-hmm. Yeah. So as we said, we looked at those things, and I hope that slide might be helpful to you.
Yeah.
Preparation is really, really helpful. Knowing your volunteers, providing psychoeducation, teaching them to take care of their minds and bodies, to have strong practices, philosophies, values, self-care, as well as providing frequent opportunities, at least monthly, for people to come together to process, as well as special opportunities, perhaps for ritual, for arts practice, for massage. We can be creative. Ask them what they would like, what would be helpful. Asking is often the most helpful thing to do.
And I should point out that that actually came in this morning, so before they'd actually listened. So yeah, I'm sure they've taken lots from the actual presentation as well, specifically. Just putting a shout out, are there any more questions? And obviously questions may come to you later, perhaps. Do feel free to send them to us. But there is an opportunity now through the Q&A process to write up a question for Lila to have a look at and try to answer before we sign off. Oh, there's a new message in chat. Let's just see if that's and I'm going to get to this as well, but thank you. Thoroughly enjoyed your presentation, Lila, from one of our participants, and I'm sure yeah, it looks like there are, oh, hang on, something's come in from a question box. Can you see that one?
I can see that. Yeah, who only volunteer once a month. Well, I think talking to them about that. Maybe they're only volunteering once a month, but are they willing to participate in some of the offerings that the community makes for their support? And I think, good assessment, really knowing them. If you have someone who, is very healthy and well and feels that they don't require support and they just want to do that piece of work, at the 1737 line in the last weeks, there have been some psychologists who've just been dropping in and out. They're volunteering, but they may not need a lot of support, or they may feel well supported in their own lives. What's the HSWA? Oh, is that our health and safety regulations? Where does
There's a question.
Well, I just think we need to do it, and I know it's really hard to do it. But it needs to be a priority. I meet too many helpers who are unwell because they're constantly pouring themselves out to others. And I do believe that our systems take advantage of our self-sacrificing nature. I know a lot of people in the helping professions who are quite exhausted a lot of the time and find it hard to say no. So I think we need to fund taking care of people so that they can continue to take care of others. Does that answer your question, Peter? Or maybe I'm just grandstanding.
Okay.
Okay. Yeah, I feel strongly about that.
He said yes. Yeah.
Oh, yes, that's an interesting question from Connie. Yeah. It can take time. I think psychoeducation first can be really helpful. Why would we want to do that? And if we are willing to do that, who would we be comfortable doing that with? It may be that it's not us, it may be their peers that they prefer. And it's quite a journey, isn't it? I think first of all, it's about being able to regulate the sensory experience, to calm ourselves and to find some stability before we can sometimes start to open toward creating a narrative. Does that help?
Yes, just to give that question some context, as a person mentioned that some people didn't know the question. So the question that you've just answered was, any tips on helping people create a narrative to transfer from sensory experience? Some of my volunteers struggle to open up to me and or others.
Yeah, that's right.
Yeah.
And if they are overwhelmed by that experience, then they probably would benefit from some, it could be professional care or particularly cultural support. Because this sounds a little bit like that sense of, getting stuck. Sometimes we get stuck in our healing process, and whatever it is, whether it's the experience we had or it's our history, it kind of acts like a glue that prevents us from moving forward. And sometimes some special care needs to be taken to unravel, whatever that is that's getting in the way of healing and forward movement, which really is about learning to live with, isn't it? Not about forgetting, but learning to live with.
So I think we've, I think there's a specific question coming from Carol Armstrong. We might make that the last one, given the time frame, if that's all right, Lila. So
I'll just say to everyone, Connie responded and said, so debriefing may be better to start by regulating and calming before unpacking the details. Absolutely. And it's quite critical as well around unpacking, that we know how to unpack carefully. That's a whole specialty, the area of trauma therapy. So you might like to get a clinician in to help you a little bit with that, because unpacking needs to happen within what we call a therapeutic window. So we don't send people packing with their baggage in a mess, so to speak. So at the end of that session or that group experience, people feel safe and calm, and they're able to return to their lives.
Sorry, I'm managing questions across both chat and questions. I think that is probably time for us, and it's there are more questions, and I'm sure there'll be lots of things that come out of this which we may be able to address at another point. But I'd just like to say a huge thank you to you, Lila. I'm so grateful that you were able to come and share your knowledge and wisdom with us today. I personally have taken away lots of new ways of kind of thinking about things. So the awareness of lived experience, thinking about it in that framing is really awesome. The compassion fatigue as a term, and then also thinking generally about the structural support that we provide for volunteers. So those are things that kind of jumped out at me, and I love that you've given us a slide with just a whole pile of strategies, which I'm going to go back to and read and reread. Just to everyone who has been here today, thank you so much. So we will be sending out a follow-up email with a link to the PDF of the slides, and as Lila mentioned, she has included in that some additional kind of reading and research. If there's something in here that you want to learn more about, there may be something within the research that she's provided us that you could have a look at. And we also hope to next week put the content of this up as a video with our other webinars on our website. So that will be something that you can access and rewatch or share with other people or volunteers. So if there's something in this that you want to share, then that's an opportunity coming up next week. But yeah, thank you so much, Lila.
You're welcome. And may I just say that, trauma is with us, isn't it? It's part of life, everyone. And, you know, I've experienced vicarious trauma in my own work, and a lot of compassion satisfaction, actually, you know, which is that other side of compassion fatigue. And so let's all be good stewards of this reality, so that we can continue to be present for ourselves and others going forward. Thank you so much. Go well, everyone. Thank you. Bye.
Bye. There's someone just asked about a CPD certificate, Peter, of this attending this. So that is something I'll think about offline, Peter. But it's a really good question. But I'm not sure how that would work. Thank you. I'll turn it off now.
Bye-bye, everyone.
Bye. And in meeting.